Namaste. Today we shall discuss about cervical spine pathologies, clinical examination, and differential diagnosis, including rehabilitation and treatment. Here you can see axial view of spine. You shall able to see posterolateral disc prolapse causing neural foraminal stenosis. Here there is ligamentum flavum thickening which causes spinal canal stenosis, and in this facet joint arthropathy causes neural foraminal stenosis and spinal canal stenosis. Osteophyte formation of body of vertebra causes neural foraminal stenosis. In this picture, there is posterolateral disc prolapse which causes neural foraminal stenosis. If it is centrally, that means direct posteriorly, then it causes spinal canal stenosis. Ligamentum flavum, which runs through the posterolateral aspect of spinal canal connecting lamina of vertebra, causes that thickening of ligamentum flavum, or hypertrophy of ligamentum flavum causes spinal canal stenosis. And here, facet joint arthropathy or facet joint hypertrophy. Facet joint is actually an apophyseal joint by diffusion of superior articular process and inferior articular process of just below and above vertebra respectively. And here there is osteophyte formation of body of vertebra which causes neural foraminal stenosis. This is oblique view X-ray of cervical spine, in which we shall able to see neural foramen in oblique view X-ray. Oblique view shall be prescribed like this in cervical spine: AP oblique or PA oblique, left or right 45 degree. AP oblique, right 45 degree, or AP oblique, left 45 degree. PA oblique, right 45 degree, or PA oblique, left 45 degree. Here the neural foramen is intact. In this X-ray, we can see anterior osteophyte formation. Here, along with anterior osteophyte formation, there is posterior osteophyte formation too, which causes neural foraminal stenosis. Whenever there is cervical spondylosis due to the osteophyte formation of posterior body of vertebra, then it shall be diagnosed by taking oblique view X-ray of cervical spine. Coming to inspection of cervical spine, undress the patient up to waist and initially check whether there is asymmetry in supraclavicular fossa by comparing both the sides. It occurs due to Pankos tumor, a tumor occurring in the apex of lungs. Check whether there is torticollis, and most important thing regarding inspection is 1/3 cases of abnormal head posture is due to weakness of ocular muscles, which shall be referred to an eye specialist for detailed examination. Palpation of cervical spine includes palpation of spinous process from above downwards, superior to inferior. After that, palpate 2 centimeter lateral to spinous process of either side to check whether there is facet joint arthropathy. In cervical spine, facet joint is situated 2 centimeter lateral to spinous process, while in lumbar spine, it is 3 centimeter lateral to spinous process. In cervical spine, palpate 2 centimeter lateral to check whether there is tenderness and facet joint arthropathy. And if there is facet joint arthropathy, we shall feel crepitus in flexion and extension, and it shall also be checked. Please note that the most prominent spinous process is that of T1 and not the vertebra prominence C7. Please note, I repeat, the most prominent spinous process is that of T1 and not the vertebra prominence C7 in palpation. Regarding range of motion of cervical spine, forward flexion normal is 80 degree. That is, the patient's chin should touch the sternoclavicular joint in complete flexion like this. Normal is 80 degree. Out of this flexion, most flexion occurs in between the atlanto-occipital and atlanto-axial joints. Most forward flexion, nearly half of forward flexion occurs in atlanto-occipital and also atlanto-axial junction. If the patient's chin is not touching the sternoclavicular joint, please note and measure the difference in between chin and sternoclavicular joint as part of recording and documentation. In extension, normal degree is 50 degree, and in extension, the patient's face upper limit like this. If the patient looks like this, the patient's face and ceiling should be in two parallel lines. Extension is 50 degree. Total flexion and extension includes 130 degree, and extension causes stenosis to neural foramen. If there is neural foraminal stenosis, either due to posterolateral disc prolapse or due to facet joint arthropathy or osteophyte formation of body of vertebra, then in extension, it causes radicular pain, which compresses the neural foramen. In flexion, the neural foramen opens up. In lateral flexion is like this. Lateral flexion normal is 45 degree, and the patient slightly shrugs, the ear touches the shoulder. Rotation is 70 degree or 80 degree. In between 70 and 80 degree, it's cervical rotation. Cervical rotation is like that. If maximum cervical rotation is done, then the patient can look in parallel to the horizontal line shoulder joint, and rotation mainly occurs in atlanto-axial joint. Limitation of lateral flexion and cervical rotation is the early finding in cervical spondylosis. Actually, in cervical spine, the most common cause which causes pain, is cervical spondylosis. The most common cause of shoulder pain is also cervical spondylosis of C4 and C5. Most common site of spondylosis and most common site of disc prolapse in cervical spine is C5, C6. I repeat, most common cause of pain in cervical spine and shoulder pain is the most common cause of cervical and shoulder pain is cervical spondylosis, and shoulder pain occurs when there is C4, C5 compression. But most common site of cervical spondylosis and disc prolapse is C5, C6. Lateral flexion and cervical rotation is limited in cervical spondylosis. It is the early clinical finding of cervical spondylosis. Coming to the clinical examination of cervical spine, it includes mainly Sperling's test, cervical distraction test, and cervical flexion rotation test. Sperling's test is to rule out whether there is lower cervical spine disc prolapse or neural foraminal stenosis. Cervical flexion rotation is mainly to rule out upper cervical disc prolapse. In Sperling's test, we can do Sperling's test in two ways. One is extension of cervical spine and lateral flexion of cervical spine in extension. This is the one way. Second one is extension of cervical spine and cervical rotation of spine. In this particular maneuver, the patient felt pain towards the affected lip. If we are checking Sperling's of right upper limb radiculopathy due to lower cervical lesion, in that case, Sperling's give correct clinical diagnosis. When we check like this, extension of spine and then flexion like this, this causes neural foraminal stenosis of right side, and there is radiculopathy towards the right upper limb if there is neural foraminal stenosis. And if we check like this, extension and lateral flexion towards left side, then it causes radicular pain towards left upper limb. I already said that it shall be done in two ways. One is extension plus lateral flexion, or it shall be done like this, like extension and then rotation rotation like this. It causes a radicular pain, either extension and lateral flexion or extension and cervical rotation. In either ways, Sperling's test shall be done, and it is to check whether there is neural foraminal stenosis of lower cervical spine, mainly C4, C5, C5, C6 and C6, C7. In Sperling's test, if the patient came to OPD with typical radicular pain, then that radicular pain will aggravate on doing Sperling. Or if the patient come to OPD without radicular pain, when the patient presents in OP, there is no radicular pain, but when we check this test, if there is neural foraminal stenosis, then the patient felt radicular pain. If there is no neural foraminal stenosis, then there won't be any pain. If the pain aggravates due to Sperling's test, you shall do cervical distraction test. In cervical distraction test, what we are doing is, it can be done in sitting posture or supine posture. In sitting posture, the patient should be in sitting position and examiner stands behind the patient and hold the mastoid process with thumb and middle finger of one hand. Hold the chin like this and do cervical traction. In this posture, do the cervical traction. The patient is in sitting posture and examiner is standing behind to the patient, and then with one hand's thumb and middle finger, hold the mastoid process and then support the chin and do the cervical traction, which relieves the radicular pain immediately. By giving traction, immediately the radicular pain subsides. The second way of cervical distraction test is in supine posture like this, as the patient to lie on your forearm, the cervical spine rest on forearm, and then do extension of cervical spine like this. Chin should be pulled up. That means cervical extension is done by supporting cervical spine in forearm. This also causes traction of cervical spine, which immediately relieves the radicular pain. If Sperling's test is done and it is positive, you shall confirm it by doing cervical distraction test. And it is cervical flexion rotation if the patient felt occiput headache, which is radiating towards temporal region, and also patient have headache, then surely it's due to upper cervical lesion. And in this upper cervical lesion, you shall check cervical flexion rotation. In cervical flexion rotation, passively flex the cervical spine and do cervical rotation. In this manner, if the patient has upper cervical lesion, the patient felt radicular pain towards right side. And like this, if it's done passively, flexion and cervical rotation towards left, then the patient felt radicular pain towards left side. Sperling's cervical distraction and cervical flexion rotation includes the clinical examination of cervical spine. Here in this video, regarding the principle Andara, Andara, Gulfior Andare in Gridrasi, in the Tika it's explained Vishwaji, Shiprasya, Dwangula, Ubari, Rektamoksha. In cervical radiculopathy pain, we are doing Rektamoksha mainly near to the Shiprasya, Dwangula, cephalic vein shall be punctured, or a vein which is very close to that particular area. The Samyak Lakshana of Rektamoksha is Laghom Vedana Shandur Vyadur Vega Parikshaya Samyak Visravide Lingam Prasado Manasastada, and the Samyak Lakshana shall be seen after Rektamoksha. As pre-operative procedure, Sadyasneha shall be given 48 minutes prior to procedure, and after Rektamoksha, you shall protect Agni and Vayu of patient, which aggravates due to Rektamoksha, so it shall be protected, and give solute replacement therapy after the Rektamoksha. Immediately after the Rektamoksha, the patient felt good relief for radicular pain, numbness, and weakness of the affected limb. In cervical radiculopathy, we are doing Raktamoksha from Shiprasya Dungula Ubadi, you shall able to see Prasado Manasastada after the procedure. You shall able to see the patient felt relief after radicular pain after the Raktamoksha. Coming to rehabilitation of cervical spine. The management of cervical spine includes Amapajana initially and then internal Sneha Prayoga. Internal Sneha is very much important to avoid recurrence. And in the initial phase, if there is true radicular pain towards affected limb, you shall do Raktamoksha for immediate relief of radicular pain. And when the pain subsides, start rehabilitation. In the initial phase, isometric rehabilitation shall be advised without movement. Give equal and opposite pressure towards hand and head in these four areas. Flexion is prevented. Here extension is prevented. Here lateral flexion towards left and towards right is prevented. And cervical rotation shall also be prevented by keeping hand here. Cervical rotation, and it shall be done 5-second hold into 10 times. This is scapular setting. In this, actually, the shoulder joints are keep moving towards posterior side and hold it for a while. This is cervical flexion in supine position. Very small flexion is to be done and hold it for a while. Bhujangasana is of very effective in cervical radiculopathy disease after complete relief of pain. This isometric exercise shall be advised in the beginning phase, in the first phase of rehabilitation, this exercise on second phase, and in the last phase. After complete relief of pain, you shall advise Bhujangasana, which gives good relief and to avoid recurrence. Use of internal Sneha Prayoga, Rasayana, and rehabilitation is inevitable to avoid recurrence. And for Shuddha Chikitsa, that means the patient shall able to continue all the activities same as that previous to the symptoms. For that, we shall give internal Sneha Prayoga, Rasayana, and rehabilitation. Rehabilitation shall be advised regularly to cervical protrusion and extrusion patients. That means second stage of disc prolapse and third stage of disc prolapse. And in cervical spondylosis also, patient shall be advised to continue the rehabilitation regularly with proper posture correction. The posture correction is also of utmost importance regarding cervical spine. The patient should be advised to avoid cervical flexion continuously in this posture like this. If cervical flexion is continuously done for a prolonged period, then also there is a chance of recurrence. And please advise and educate the patient about the importance of postural correction. Coming to cervical spine, we discussed the clinical examination. In the initial picture, we saw the causes of neural foraminal stenosis and spinal canal stenosis, which includes the neural foraminal stenosis is occurred due to posterolateral disc prolapse, facet joint arthropathy, and osteophyte formation of body of vertebra. Spinal canal stenosis is due to ostrocentral disc prolapse, ligamentum flavum thickening, and facet joint arthropathy. Then we saw the importance of oblique view X-ray in cervical spine to rule out cervical spondylosis and posterior osteophyte formation of body of vertebra, which causes neural foraminal stenosis. Then we learned the clinical examination regarding inspection, palpation, and then range of motion. The degree of range of motion shall be monitored using a goniometer before the treatment and after the treatment for purpose of documentation. A spatula kept in between clenched teeth shall be used to check the extension, flexion, lateral flexion, and cervical rotation. And then coming to the specific clinical examination test to check the radiculopathy. For lower cervical lesion, first you shall check Sperling's test, that is extension and either flexion, lateral flexion, or cervical rotation. After Sperling's test, which aggravates the pain if there is neural foraminal stenosis, You shall continue with cervical distraction test, which relieves the pain. Positive cervical distraction test means the reduction of symptoms shall be assessed in cervical distraction test by giving traction to the cervical spine. For upper cervical lesion, cervical flexion rotation, flexion of cervical spine plus rotation of cervical spine gives positive result. And regarding management for immediate pain relief, we shall do Rakta Moksha, Siraveda, just 2 centimeter proximal to Shipramarma, Shiprasya Dungula Ubadi is the site advised in Tika, where Andara Kandara Gulfio Andare for Gridrisi is explained, and this particular procedure is very effective in the initial management phase to get relief immediately, which persists for a long period also. And regarding the correct management protocol, initial Amapajana is of very much utmost importance. Avoid snana at night. Regarding cervical spine, Tala is very important. And after complete Amapajana, go for internal Sneha Prayoga. And along with internal Sneha Prayoga, when the pain subsides, start rehabilitation. And after the completion of Sneha Prayoga, we shall give Rasayana to avoid recurrence. Proper postural correction is of utmost importance. Coming to rehabilitation, initial movements include isometric rehabilitation, and then exercise with movement shall be advised. Bhujangasana shall be advised at the last phase of rehabilitation. Hope you understand the clinical examination, differential diagnosis, and management includes, which incorporates rehabilitation in cervical spine. Thank you.